All right, what is up, PT on Ice crew? Got YouTube over here, Instagram over here. I am Dr. Mark Gallant, lead faculty for the Ice Extremity Division, alongside Dr. Lindsay Huey and Dr. Eric Chacones. Pumped to be with you on this Clinical Tuesday. We're gonna get into a little more discussion about tennis elbows. So last time I was on here, we talked about the 30,000 foot view of treating elbow pain patients overall. This week, we're going to get into a little bit more of the details. Before we do that, I just want to give a shout out to Onward Milwaukee. Drew and Kelly had a wonderful time hanging out there and solving a lot of these extremity problems over the weekend. And then, of course, to Kristen Wellencotter, thanks for helping out. And Gmo, thanks for being there. Just a quick update on some courses this weekend. We've got bike fitting in Minnesota. We've got Fitness Athlete Live down in Greenville, South Carolina. And then the pregnancy and postpartum live course is going to be at Onward Bellingham in Bellingham, Washington this weekend. So if you get a wild hair and you want to jump into a course over the weekend, definitely check one of those out. So as far as treating lateral epicondylgia, so most of the research is in the lateral elbow. Unfortunately, we just don't have the breadth of research for the medial elbow that we do the lateral, but you can take a lot of these things we're talking about with the lateral elbow and just flip them onto the other side, and they tend to work quite well overall. But one of the biggest things that we have to do when it comes to specifics for treating the lateral elbow is to be willing to unload these patients a bit and be willing to have the honest conversation about unloading the stimulus that's causing the aggravation to the elbow. So, and this can be a bit of a big challenge. You know, if you've got someone who works a manual labor job or a factory job, and they literally have to use their hands all day to get the job done, or if you've got a high level athlete who depends on their limbs to participate at a high level in their sport, it can be a bit of a sensitive subject. But especially with dealing with lateral elbow pain, we need to unload the tissues to allow them to calm down a bit so that we can then progressively load them later on. So oftentimes having the tough conversation with the patient of, for the short term, we don't need to stop the activity completely necessarily, but we need to decrease the volume or potentially decrease the vigor of the load being placed on these lateral elbow structures. Absolutely, you can use some techniques like taping or some over-the-shelf braces that can help unload those tissues a bit so that you can get the person to continue their activities more. But there needs to be some conversation of that we need to stop the bleeding a bit with these types of pathologies. As far as pain modulation, so again, we talked about early on, most of these individuals are coming to us with pain. We want to have some techniques in our tool bag to try to quickly decrease the pain overall, whether that's myofascial decompression, whether that's dry needling, joint manipulation. All of those are going to work well. So whichever one of those is in your tool belt, go ahead and give that a whirl. We really like to dry needle the lateral structures of the elbow. So getting after that extensor carpi radialis, extensor carpi ulnaris, extensor digitorum, supinator, and then certainly have the lateral triceps in your chain if you're able to hook up circuits. And those tend to do really well as far as a pain modulation perspective for lateral elbow pain. And then we want to get into loading them. So we want to unload the overwhelming stimulus, but then we want to start building up load for our lateral elbow patients. What we found that works the best is to do isometrics. So Ebony Rio really gave us a lot of research in the lower extremity as far as how to most effectively load up our isometrics for patients. What she uses is 5 sets for 45 seconds at a fairly heavy load with a 1 to 2 minute rest in between. Now, the research is not shaken out as well for the lateral elbow with isometrics. There's only been a couple studies. They didn't use isometrics in isolation. So we don't really have a study to really hang our hat on. But anecdotally in clinic, what we're seeing is that 5 sets of 45 seconds does work quite well. And Leanne Bissett out of Australia, who's one of our premier lateral elbow tendinopathy research, is also using that 5 sets for 45 seconds anecdotally in clinic. So a really nice place to start. Now, some differences between the lateral elbow and the lower extremity that you may need to use to get these isometrics to work well for you. In the lower extremity, loading into pain, tends to work really well. So allowing your patient to get to that 2 or 3, maybe even 4 out of 10 pain while they're loading, patients tend to respond really well. Not so much in the lateral elbow. It seems that for the upper extremity tendinopathies, we need to keep that pain a little bit lower. So oftentimes we're telling our patients, we actually don't want any pain while you're doing this. What that may mean is you may not be able to get 5 sets of 45 seconds day 1 or day 2. We may need to build up to that. It may be, hey, we're going to get 3 sets of 25 to 30 seconds. And then over the next couple weeks, we're going to build into your 5 sets of 45 seconds. The way we're going to load this is we're going to have a slight wrist extension and loading into pronation. So slight wrist extension, pronated, and loading those tissues up. Again, shooting for that 5 sets of 45 seconds. We're going to go into an elbow bent position to start based on the person's irritability. And as they become more comfortable and they can tolerate more, we're going to go from elbow bent to elbow straight out. Now, you may need some other tricks to get into that in a comfortable way. This is a wonderful place to use some gliding techniques and some self glides to try to get that pain free. So we really like lateral ulnar glide. So putting that force on the lateral ulnar while they're holding their pronated, slightly wrist extended, or a PA radial glide. So the person's going to hold their PA radial glide while they're holding that isometric. And that oftentimes allows them to get into a more of a pain-free isometric situation. Once they're able to do that bent elbow pain-free, whether they have to do the glide or not, then slowly but surely over the next couple of weeks, we're going to try to get them into that more challenging elbow extended position. Now, once they're able to tolerate isometrics well, and they're moving through that and their functional asterisk signs are starting to improve, then we want to get into our heavy concentric eccentric exercises. What we find to work the best is supination and pronation at the elbow. Oftentimes, when we're looking at functional activities in life, the wrist is stabilized in extension. So a slightly extended wrist while the elbow is either supinating, pronating, or the forearm supinating, pronating, and the elbows flexing, extended. So that's exactly where we want to go with our treatment. So it works best if you have some sort of weight that's a bit top heavy. What we really like is one of these old school dumbbells where you can add load to the top and you can keep the bottom of it absent from load. And then we're just going to have that person start elbow bent, performing their pronation and supination. Again, they may need to apply either that lateral ulnar glide or the PA radial glide to get that to be pain-free, and then building up from there. Same progression that we talked about with the isometrics. We're going to start with a bent elbow, which tends to be easier, and then we're going to work them into a straight arm technique, doing their pronation supination. As far as the dosage for our pronation supination, we like to use what we at ICE call the rehab dose. So what the rehab dose looks like is it's going to be 8 to 20 repetitions at an intensity of 30 to 80% of their 1 rep max. You might be saying, Mark, those are pretty wide buoys as far as a rep scheme and an intensity. How am I ever going to pick a right intensity for my N equals 1 patient? What we're going to use is their irritability. A patient who's higher on that irritability scale, we want to go higher volume repetitions, so closer to that 20 at a much lower intensity, so closer to that 30%. Because our goal at that time is to take some of the tensile load out of the equation when they're in a higher irritability state and really act as a pump there. We want to get a lot of fluid exchange, pump those chemical irritants out of the area, and then as the person can handle more tensile load, we're going to start, again, increasing the intensity. So maybe inching up towards those 50, 60, 70% intensities, but bringing down the overall volume of the sets. So getting closer to that 8, 10, 12 rep range for 3 to 4 sets. Now, once the person is able to tolerate that, so you're getting closer to that increased tensile load, your 8, 10, 12 sets, higher intensity, they're able to now extend their elbow all the way out. Then we want to start getting more functional. A bent over row is one of our favorite exercises to give our elbow tendinopathy patients as a more functional exercise. It just emulates what we do in real life so well. Again, that pronated grip, slightly extended, is how we tend to carry and pick things up in life. So getting that bent over row will hold that wrist in an isometric extension while they're working using their lats and their elbow flexors to get a nice overall stimulus. With that bent over row, again, same thing. We're going to start with that rehab dosage, 8 to 20 repetitions, 30 to 80% of their 1 rep max for 3 to 4 sets. As they begin to tolerate that bent over row more effectively with less and less elbow pain and less functional asterisk pain, then we're gonna start getting more into a strength dosage. So can we build into a heavy 5 sets of 5 above 80%? And that's what we're going to be working towards with that bent over row. Now, during this whole process, you want to be building that person's entire upper quarter capacity in a relative pain-free manner as soon as you possibly can. So I'm trying to find day one, what is some sort of upper quarter exercise that's going to hit a majority of the muscles that my patient can do pain-free? If it's the bent over row early, sweet, let's go right for that. If not, can they knock out push-ups relatively pain-free? Can they knock out overhead press pain-free? We want to get a big, robust upper quarter stimulus early on. So that may happen visit 1, visit 2, visit 3. What can you do while we're working on these local tissues that we can start to build up your overall upper quarter capacity at the exact same time? Now, the final step, you've got your isometrics, 5 sets, 45 seconds, relatively pain-free. Then you've built into your concentric eccentrics with pronation, supination, using the rehab dose, 8 to 20 reps at an intensity 30 to 80% with a minute to 2 minute rest in between. You've built into your bent over row, starting with the rehab dose, building into a strength dose. And then what we want to do to get that person truly back to their functional activity is to start adding speed into the equation. These tendons tend to be challenged by adding speed. So if we're looking at the mechanic or the factory worker, maybe we need to start them out with a hammer or a screwdriver and start really slow. So they're hammering at a pace of 1, 2, 3, 4. And then we get a metronome going. And every few visits, they have to build the speed of that hammer up. 1, 2, 3, 4, 1, 2, 3, 4. Or maybe it's a screwdriver starting slow at 1, 2, 3, 4, and then eventually building up to a much faster pace. If it's a fitness athlete, we may be starting them slowly back onto the rig, building up the tempo and the speed of their kipping, their Olympic weightlifting, starting at a very low volume, the same way you would progress your concentric eccentrics, and then again, building up the volume and the speed over time. So just to recap, we may need to unload the tissue for a short period of time using tape, bracing, stepping back from the volume of activities. Then we're going to get to our isometrics, 5 sets, 45 seconds, relatively pain-free. May need to use some of those mulligan mobilizations to get them pain-free. Building into our concentric eccentrics with supination with the rehab dose, 8 to 20 reps, 30 to 80%. Building into that bent over row, pronated grip, slight wrist extension for the rehab dose at first, 8 to 20 reps, 30 to 80%, but then eventually building into a strength dosage where it's 5x5, 80%. During that whole period, trying to get some functional strength overall in the activity they can do, overhead press, push-ups, pull-ups, whatever that may be, and then finally getting that speed component. Can they use their screwdriver fast? Can they use their hammer fast? Can they build the dynamic speed on the rig? All right. Hope this was helpful. Would love to chat more about it in the chat bar. Would love to see you on the road at a course. Definitely hit us up and have a great Tuesday in clinic.